Hello, everybody. My name is Dave Crawford. I'm the Director of Training and Development at CASAC Trinity, if we have not met yet. Today's training will be on person-centered care and substance abuse treatment. And this training was decided by myself and some other leadership because I first like to say I am definitely an advocate of person-centered care. I believe in it. I think it is crucial to see the person and work with the person, not their diagnosis, and develop treatment goals that are effective in what we're trying to do, and that is maintain a program of sobriety and engage a person in recovery. That can take a while. It can have multiple attempts. It involves an element in the beginning stages where stabilization and harm reduction are crucial, but that end game and the end goal is always going to be abstinence and an improvement of quality of life. So person-centered care. Person-centered care is about care approaches and practices that see the person as a whole with many levels of needs, goals with these needs coming from their own personal social determinants of health. If anybody's familiar with social determinants, it can be like the functional areas in the treatment plan. It can be legal, vocational, social, housing can be a social determinant, medical, all that is social determinants. And the more we can wrap a client in services as part of treatment plan, a lot of research shows different elements have higher chances of success. Like off the top of my head, I know that family involvement in relapse prevention planning, I mean, appropriate family involvement. Sometimes we have something else going on, but when the family's involved and we're supportive of recovery, involving them in relapse planning can show a 50% reduction in relapse rates. I know, including a vocational component of treatment planning, that would also decrease relapse rates significantly. And I know the research shows when a person does not have housing conducive to sobriety or a difficulty maintaining sobriety outside a structured environment, sometimes inpatients and long-term residential programs, whether that be an intensive residential like an 820 stabilization rehabilitation or all the way down through levels of care, which was always the ideal and the best course of treatment, because the OASIS locators are founded in and built on ASAM criteria, which if you would like to Google, ASAM criteria has 20 years of supportive evidence that defines these levels of cares, and kind of the research just shows you sort of use it like clients meets that criteria. For, like, say for inpatient, starting at the top, detox inpatient, it's like you wrap that client in a big blanket and you hold them tight, and the levels of care moving down are evidence-based support. You slowly are kind of releasing that structure to give the client what they need and the abilities to start working a program of recovery. And they should follow a sequence in steps. In real practice, in real life, it's not always perfect, but ideally, and the best would be, let's say, detox inpatient, followed by stabilization, followed by rehabilitation, community residence, and then supportive living, and then independent living programs. So hence, to be person-centered means being responsive to holistic needs and to tailor care to individuals or group specific characteristics, abilities, and potential. Hence, to be person-centered means to make recommendations that give the client the absolute best chance of success and a best fighting chance in their recovery. So I do have a short video here that defines the videos. I mean, it was very hard to find person-centered care exactly for addiction. So they really just outline person-centered care in more general sense, whether it be medical, mental health, or our setting. But we will watch and we'll unpack a little bit on how they apply to us.
It's just, the nature of us as nurses to care for people.
I could not have made it.
We are all on a personal journey of growth and discovery. Our individual journeys allow us to pan for agency within and draw on the resources that are available to us, the sun, the air, the soil, and proactively seek out support. This might be water to survive and grow, or fertilizer to flourish and blossom. This applies equally to people with personal and professional experience of mental health. Connecting with our own struggles leads us to think about the nature of resilience, how it can be developed, and is reflected back in how we support others. Person-centered care planning is an important tool on this journey of self-discovery. It has increasingly been recognized as a key intervention to restore fundamental freedoms to people living with mental ill health and to transform the systems of care which serve them. The potential power of this strengths-based approach has led to a call for its widespread adoption by many stakeholders around the world. But despite the urgency, there is confusion about what person-centered care planning looks like in practice and how exactly does it differ from traditional models of treatment planning. What a meaningful life looks like to the individual will determine what that person needs to thrive and flourish. So not only does it take various forms due to the personal needs and strengths of the individuals, but even for the same individual, it can take different shapes and colors depending on where they are on their recovery journey. So no one size fits all. We might find ourselves asking, is there enough water or too much? Do the roots need airing? Do we need a trellis or protection from the frost? Or is it time to stand back and give space to the person to grow? There is no simple formula. However, in considering high-quality person-centered care planning, we have found it helpful to think of 4 aspects, each beginning with the letter P: philosophy, practice, plan, and purpose. Person-centered care planning recognizes that mental health systems have for too long fostered dependency and had low expectations for people living with mental health challenges. In this sense, the first P of person-centered care planning is its focus on purpose. In the early phase of recovery, the right support is needed to navigate the twists and turns of the journey. However, person-centered care planning goes far beyond the reduction of hospitalization or maintenance of clinical stability. It holds high expectations for meaningful individual outcomes across a broad range of quality of life areas and achieving one's potential. The philosophy that underlies person-centered care planning is perhaps the most important aspect. Person-centered care planning can only grow out of a culture that fully embraces recovery, self-determination, and community inclusion, believing that people can and do recover, believing that people can and should have choice in the decisions that impact their treatment and their lives, and believing that a meaningful life in the community is a fundamental right and not something that must first be earned through acts of compliance or demonstration of clinical stability. These beliefs are the bedrock in which person-centered care planning is rooted. Next is process. Best practice person-centered care planning is about much more than the treatment plan document itself. Person-centered care plans must be rooted in a mutually respectful and healing relationship between a practitioner and the person being served. Establishing and maintaining such a relationship may involve a major shift in how we partner with service users before, during, and after planning meetings. Do we educate people about the promise of recovery from the point of first contact to nurture hope and self-activation? Do we practice strength-based, culturally sensitive methods of assessment? Do we invite people to actively involve friends and family in person-centered care planning meetings to strengthen their circle of support, which helps sustain their recovery in the community? Do we provide education to service users so that they can be prepared to participate as equals in the person-centered care planning process? Do we support the dignity of risk and right to fail and maximize the use of self-directed wellness or advanced planning tools? Do we share a copy of the co-created plan and offer people an opportunity to review it, make revisions, and even disagree? These are the questions person-centered care planning practitioners challenge themselves with on a daily basis. Sharing one's experience of person-centered care planning with fellow colleagues will give rise to more questions. If an individual practitioner can recognize the person they're supporting as their guide, answers will blossom, bringing passion to purpose and progress to practice. The person-centered care planning philosophy and process ultimately informs the co-creation of the recovery plan itself. The person-centered care plan can be thought of as an agreement between a person and his or her network of supporters, an agreement that outlines a more hopeful vision for the future and how all will work together to achieve it. Content of the person-centered care plan is expressed in person-first language, and goal statements are articulated in the person's own words. They focus on the pursuit of a meaningful life in the community, not just symptom reduction or treatment compliance. Goals are then broken down into meaningful and measurable short-term objectives that help the individual to overcome any barriers which may be standing in their way. These barriers may include mental health challenges or contextual issues such as stigma, and discrimination. Short-term objectives enable an individual to organize what can feel like an overwhelming journey into a series of smaller, manageable steps, all the while sending the hopeful message that we all believe that things can and will change for the better, and soon. Finally, quality person-centered care plans draw on the person's identified strengths to develop goals, objectives, and a range of interventions, including those that go beyond traditional mental health services like peer support, holistic or culturally specific healing practices, and self-management strategies. People receiving mental health services essentially want and deserve the same things out of life as anyone else: a home, family, faith, health, a valued role in society. People want to thrive in their recovery, not just survive their illness. And person-centered care planning is one tool we can use to help people in this process.
All right, that is person-centered care in a nutshell. And I'd like to jump on some key points that I like what the video said. In the beginning, if you can recall, he said something similar to that in person-centered care, there is no perfect recipe. And it's sort of this balance on, like, as the professional working with what the client may need, but then also there's times when we have to recognize at the professional, it's time to give that person space and allow for them to grow and reach the potential and become who they are meant to be, sort of thing. And I think that plays into seeing the person as a person and not the diagnosis of an addict. And I think of those two things, like the difference between early recovery and advanced recovery. I mean, early recovery, we see a lot of resistance and we see a lot of continued use and we see a lot of justification and evasive behaviors. And at that time, that's the time where I think we're focusing more on clients' needs and trying to wrap them in services and develop a plan collaboratively, as always. I mean, you want a client to be part of that decision making, but also that resistance isn't necessarily an indicator to just give up. That resistance is an indicator that it's time to kick in our clinical skills and start working on getting through some ambivalence, discrepancy building, and whatnot. And I mentioned that a few times further on. I also like that that one part where, actually, I already said it, I'm sorry, seeing the person and not the addict, because I think when we kind of just roll with that, especially in early recovery, and I mean, don't get me wrong, as a counselor, my whole beginning phases were to kind of, my core was in motivational interviewing, where I would just follow that client and I would watch and throw out some stop signs or yields and watch as they were headed off a cliff or right into a brick wall. You know, I'm not going to get in front of, because that would go against the learning opportunity and the way I've been trained, but I definitely try to influence to make the right decision. So like early on, when I'm first working with a client, I mean, there was a element of it where I'm following and they're demonstrating resistance and I'm watching them crash into the wall and I'm saying, okay, that hurt. You want to try it our way now? You want to try it the CASAC way? See what we can do here, what we can get in place. And I think just sticking with them and being supportive and being non-judgmental, but definitely still trying always to increase client buy-in on appropriate treatment planning and educate them is part of the person-centered care. And on the other end, when we just give up and kind of stop trying to give intervention, stop trying to work with the client, kind of just ignore the poor attendance, not holding anything accountability, I think that is when actually the opposite of person-centered care. And at that point, we are seeing the addict and not the person at all. And it's just kind of, oh, well, that's what they do. And I think that totally goes against that person-centered care planning. And I also think that holistically in the field, there seems to be a belief that somehow that self-direction there that has extreme health and social negative consequences would also be in alignment with personal care, because that is what the client is choosing to do. And that is the purpose of this training, to kind of try to educate a little bit more on and around that. And with that said, we'll move on to the next slide. So person-centered care key principles is about promotion of health and well-being, is focused on the whole person care, is care for all people, partnership and participation. Partnership, I bolded and on the outline or underline, because partnership means it's not all client directive and it's not all clinician directed, but there is a collaborative component of it where we have a say. And at the end of the day, being that we are the trained credentials professionals, I mean, we also have to rely on our training, empirical research, and scopes of practice, core competencies, and best practices. Recognizes a person's right to fail. We're going to talk about that one a little bit in a minute. Sensitivity, culture, social culture, diversity, and context. It's about the key principles about quality of relationship and communication between systems and users. It's tailored and responsive care based on individual needs and not just wants. It's comprehensive, it's continuous, and it includes the client's rights and responsibility. So we're going to talk about some misconceptions that I believe that I've seen, not just live in constant conversations with different colleagues, different staff, and research, and the person's right to fail. I think the most common misconception would be related to recognizing a person's right to fail. That's a thing, and I believe in it. I mean, at the end of the day, if we're working and we're doing all our tricks and skills and strategies and our recommendations not being followed and that client wants to have a right to fail, then that's what we're going to go with. But this does not mean that the first sign of any resistance, we just throw our hands up and claim it's a client's right to fail, nor does it mean we agree to or influence and make our treatment recommendations that are highly likely to fail because that's what the client wishes. Like, for instance, I worked inpatient for a while, and if I have a client there and when I call the probation officer, they tell me that everybody they live with is abusing crack cocaine, or the client's homeless, just doesn't even have a home to go to. And we know based on our training, ASAM criteria, that like stabilization, rehabilitation, 820 services would be the best chance that they have. And that would definitely influence our decision making. And we would try to work with the client on that. And if they were resistant and saying they just want to go to emergency housing, or maybe they want to go to supported living, then I'm not just going to say, okay, that's their right to fail and co-sign that. I'm going to work with them to try to get through that. I'm like, where has being homeless got you? How does that help recovery? Supported living, I might say, because that happens often, believe it or not. And I can tell you right now, from an inpatient facility, it is very unlikely you would even find a supported living program that would take from that high level of care. There are a couple, but those were also not ones that I would feel comfortable in sending anybody, because that is such a jump in all of them evidence-based supported levels of care. So what it means is we first use our clinical skills to attempt to get through that ambivalence, like I already said, educate the client on services, work to increase buy-in, and use strategies such as persuasion, discrepancy buildings, and pro versus cons. We then make treatment recommendations, and the right to fail may be applicable here as the client still refuses to follow our professional and evidence-based recommendations. And back to that example I just gave, that would be applicable if we did all our best efforts and we tried everything we could, and that client was just still like, I don't give a damn, I want to go to emergency housing. And as much as I always breaks my heart, and I know the statistics and the probability of a client finding success that way is, I wouldn't say impossible, but it was very, very super low. I know I did the best I could. So I also know I can sleep at night. Person-centered care misconceptions continue. Patient-centered care is certainly an important piece of quality healthcare, and an important approach to empowering patients to take the active role in their care plan and treatment. However, when talking about addiction treatment, there seem to be some misconceptions or concerning trends related to patient-centered care. Let's look at addiction. What is addiction? The American Society of Addiction Medicine, ASAM, and if you're unaware, ASAM has this large body of research that supports like levels of care from everywhere, sustained recovery, all the way to detox, and like the criteria that goes along with that and how they're all related. They're worth checking out if you did not know. And I can tell you right now, the OASIS located levels of care are all based in ASAM criteria. It defines addiction, but back to ASAM specifically, defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits leads to characteristics, biological, physiological, social, and spiritual manifestation. These are the symptoms we use for criteria. This is reflected in the individual pathologically pursuing reward and or relief by substance use and other behaviors. Addiction is characterized by an inability to consistently abstain, impairment in behavior, controlling, craving, diminished recognition of significant problem with one's behavior in interpersonal relationships, and a dysfunction of emotional response. Like other chronic diseases, addiction involves a cycle of relapse and remissions. Without treatment or engagement and recovery activities, addiction is progressive and can result in disability or premature death. In short, addiction is a brain disease that impacts the patient's ability to function because their brain has been hijacked, their pleasure center is damaged, and they are constantly searching for release, comfort, and pleasure. ASAM describes this as an increased hunger for drugs or rewarding experience. This is an impairment of behavioral control, diminished recognition of significant problems, of their behaviors and a dysfunctional emotional response. So before I go further, I'm going to unpack that just a little bit. So what is that saying to me? That goes back to what I was saying about early recovery. We have a person actively using and just out there. We need to consider that when we're doing person-centered care. We need to consider where their mind is at. We're considering how the drugs are impacting or impairing decision-making, and we need to include that as part of our treatment plan. And again, I mean, it's not going to always work perfect, but that is the best clinical practice and what the research supports. And as professionals, that's how we need to be working in those cases. Patient-centered care is based on the principles of patient being involved in their treatment and treatment plan being based on the patient's preferences, needs, and values. However, what if a patient's preferences, needs, and values are compromised based on having a brain disease that impairs their ability to think rationally, to deduce what is best for them, and leaves them with impaired behavioral control, diminished recognition of the problems and situation, and an irregular ability to respond emotionally? What if the patient is not rational or have impaired ability to make decisions? And I think that the video that we watched a few minutes ago, that goes right into what the guy was saying, is when that balance, and not a perfect recipe of when to recognize when the client needs support and the services that we can offer, or balance between when the client needs space and time to grow. And when we're talking about that stage of recovery, that space and time to grow is not always the best case. I don't even mean that like it's never the best case. This is the catch-22 that arises when discussing the approach of patient-centered care when it relates to addiction treatment. Often the patient is the last one to know what they need or what is best for them. Treatment professionals, family members, friends, employers, and others are often more informed and objective in terms of what an addicted patient needs than the patients themselves. That is why, too, it's so crucial to do collateral contacts, work collaborative with any people, systems, anything that the client's involved with. I mean, that relates to that, because again, not only will that may help increase motivation. I mean, if someone's wife or husband's going to leave them unless they get help, then we definitely need to include them in the treatment process, because they haven't left them yet. And it's maybe a tough love situation or a boundary they're setting, but at the current moment, they are working in the best interest of the client. I think it applies to so many other things: family involvement, parents, friends. I think it even applies to the legal system. I mean, I have thoughts around that. I mean, I've been in this game one way or another a long time, and I can tell you, like, early 90s, it was a thing. I mean, if a client had one positive screen for marijuana, it was highly probable probation or parole was just going to lock them right up. Where we're at currently, it is not like that. I mean, so many probation officers or even social workers, and they are just as committed to a person's recovery as me, or you, or anybody working in this field. You know, especially right now with the bail reform. I mean, it's not non-existent. I mean, there still seems to be a line, but there is even more chances theirs. But it's also crucial to include these people in treatment plan and in part of person-centered care, because it's a collaborative effort and it takes everybody involved. And probation, parole, family, spouses, they know the situations better than we ever can. I mean, we can work with a client for months and they come in every week and we'll get to know them somewhat, a little bit, but also we're only knowing what they tell us because we are not actually in their environment. We are not living their lives, nor are we witness to it. So at the very least, even, I mean, I'm not saying these people need to totally influence every decision, but they at least should be part of, and definitely should be part of, information gathering. However, addiction treatment also must be respectful of patients, treat them with dignity and respect. So that's the balance. I mean, you got to invite these people in, you got to get permission from the client. They might not want to, most times they're okay with it, but maybe they don't. And that in itself might take some discrepancy in exploring and unpacking. Why is that a problem? And maybe it is a problem. Maybe the client says, my wife shoots heroin with me and I'm thinking about leaving her. So that's obviously a different thing. I'm talking about these systems and these people that are working towards the same goals we are and want to see the best for our clients. They should be involved in the treatment plan. There should be honesty and transparency between the patient and the treatment team. Misconceptions continue. There seems to be a misconception in regards to patient-centered care when examined with the context of addiction treatment. Too often therapists, treatment centers, or other professionals seem to believe that the patient-centered care means that the patient gets to direct their treatment. That is the job of the therapist or the treatment center or the professional simply give, that is the job, sorry about that. That it's the job of the therapist or treatment center or the professional to simply give options to a patient and then be agreeable to what the patient wants to do with virtually no pushback or challenging. So that goes back into the right to fail. I mean, just a little bit of pushback or resistance, that's not an indicator, just, oh, we're done, we tried. That means that we start trying to use skills that we were all taught to deal with that kind of stuff. And that the fact that we're taught in early recovery, not only do we have to deal with it, it's so common, you know what I mean? So like, that should definitely be part of our toolbox, you know? So, or another misconception is treatment centers will not employ the use of family or other relationships to try to help a patient understand what is needed and guide them into making a more rational decision in terms of treatment. A doctor would never allow a patient with stage 4 cancer to simply choose a treatment or lack of treatment plan because it was the easiest, most painless, or more comforting option. They would push back with evidence-based approaches and statistically support the best possible outcomes to do their job and attempt to save the person's lives. And maybe cancer is an extreme example. I don't think it is. I think that if statistically, you know, like the chances are probably equal or greater than that a person's going to overdose and catch cancer and or at least die from cancer. And I think it's the same type of thinking we need to have in this field. And I think that, again, we can't make a client do anything, but also if we are just co-signing, like back to the example I gave with the client resistant and inpatient wanting to go to emergency housing, if we're just co-signing that as a successful completion or that they're adhering to a person-centered treatment plan, I would say that's even unethical and very highly irresponsible on our end. Addiction treatment should be no different, but far too often patients refuse clinical appropriate treatment options, recommendation responses like, I don't want to do that, or I think I know better. And treatment professionals let it be because in their minds, that's patient-centered care. And that goes to like everything we were just talking about. It seems that an addiction treatment may have lost sight of the primary purpose of treatment, saving and enriching patients' lives. So again, patient-centered care is preference, needs, and abilities. Early on, we're focusing on needs. And yes, we're increasing buy-in and we're working to get through ambivalence. And we want the client to be active participants, but we need to kind of nurture that at first. And that's person-centered care. There's absolutely a necessity to have addiction treatment focus on patient-centered care, but there's also a need to be mindful that addiction treatment professionals are utilizing all the tools at their disposal to make sure that a patient gets the best, most appropriate clinical care that is called for in their specific situation, and not just allowing a patient that is suffering from a brain disease that has impaired their thinking, judgment, decision-making, and value system to dictate their own treatment. Monitoring a person-centered outcomes and effective monitoring for person-centered outcomes and effective interventions. Person-centered outcomes evaluation. It is a clinician's responsibility and ability to monitor their practice and promote positive outcomes. It involves assessments of needs, accurate diagnosis, therapeutic interdisciplinary, and may involve a variety of evidence-based practice interventions. It compares the benefits and harms of the interventions. It aims to find out how well interventions work in everyday practice settings, not just in clinical trial settings. I'm going to jump on that quick because that's another thing too. I think that the addiction field has changed in so many ways, but in a lot of ways it has not. And although we have all these new tools and we have these new theories that are just like, seriously, I mean, like, I'm not trying to be funny, that they do have a spot in treatment. They're a part of what we do. But it's also about matching the intervention to where the client's at, the symptoms, frequency, duration, intensity that they might be exhibiting, and recognizing that, like, let me see, DBT, I am a big fan of DBT, you know what I mean? But DBT might not be the appropriate intervention for a client who's homeless and shooting 2 bundles of heroin at that time. I mean, we get down further road and we still want to get into some of that, then we're going to use DBT. Do you get what I'm saying there? Just because we learn a new theory or a new tool, that doesn't mean like that. And that doesn't mean if we have a new hammer, everything doesn't become a nail. And at the root of it all, addiction is still based in trans-theoretical models, stages of change, and motivational interviewing and early recovery. Those are the most highly supported and I would say the gold standard. So we need to keep our practices there the best we can. And if you are not sure or disagree in any way, then I would challenge you to even check out the OASIS 350-hour curriculum for CASAC credentialing, because I would say about 80% of that is on those concepts and theories we just discussed, with about 20% being the other stuff in the add-ons. So person-centered outcome evaluation focuses on outcomes that matter to people, and what matters most is the evidence-based practice that have shown to have success as interventions to the people and help them recover. Outcome evaluations does involve shared decision making. I am not negating or saying that that's not part of this process. It definitely is. But good shared decision making means talking with your clients about what is important to them and considering it, Good shared decision making is not a one-way street where either the client or the clinician completely dictate the treatment plan. And many times it's negotiation, it's a collaboration, it takes compromise when able, but at the end of the day, it's about recommendations and treatment goals that allow the client the absolute best opportunity for success in the recovery. And that is our job. So I got a little chart here where I think that it just kind of reflects it with a visual nicely. I mean, to the left here is just going with it and letting the client totally dictate, especially in these early recovery stages. And I found this online actually, but I do agree. If we go that route, not only is it just the wrong approach, it is neglect, because we're not only respecting the right to fail, we're setting the client up to fail. On the flip side of that, we're human beings too, and maybe we're frustrated and agitated, and maybe where a client might just do fine in 820, we're like detox and stuff like that. So it is finding that middle zone and that recovery zone, and that's the person-centered part, that collaboration and that partnership, and it is imperative. But at the end of the day, evidence-based and good practices, they guide what we do in our work. Many providers feel they are already person-centered in their daily work. However, being truly person-centered often requires a far more profound shift in attitudes, policies, and practices than is often realized. It is different than the well-intended practice as usual. And that is what we are discussing today. We're trying to change the minds and the way we do things. I got another short video here that just simplifies it.
This is the checkers game where grandson and granddad will bond.
What is person-centered care? Person-centered care is where health and care professionals work collaboratively with people using their services and their communities. But what does that actually mean? It means that care is coordinated, tailored to the needs of the individual, underpinned by dignity, compassion, and respect, and enables them to live a fulfilling life. Seems like a no-brainer. Don't we already do that? Actually, it's not standard practice, but it should be. Is it worth it? In a word, yes. Person-centered care can have lasting benefits. There is evidence that it improves health outcomes, care quality, and patient experience. On the professional side, it enhances staff satisfaction. If we want to adopt it, fundamental changes to care are required. So, how do we put it into practice? There are lots of things we can do to develop people's roles in health services and to unlock their person-centered potential, to get health and care services working better together, and to help people to have the knowledge, the skills, and the confidence to work differently with their health and the NHS.
So pretty much everything we've already been discussing. Maybe I'm just looking for it to support myself, because I do want to be clear. In no way am I challenging person-centered care. Again, in the beginning of the training video, I said that I am an advocate for, and I believe in my core and fundamentally. But I do think, and along with some other people, that there is just some misconceptions about it and some beliefs and facts that have got misinterpreted perhaps the wrong way. And the purpose of the training is kind of to challenge that a little bit and try to get people thinking about it as it should be. Person-centered care is a collaborative effort between client and clinician that includes being aware of and incorporating a client's preferences, needs, and abilities. So I got some examples here that I want us to think about, and I challenge you to do so from a professional perspective. And the first would be, would a client in early recovery who reports a preference to continue using 2 bundles of heroin a day be included in a respect for patient's preferences? I mean, ethically and professionally, is that not exactly what we're doing in this setting? I mean, again, it takes a while. It might take a couple of years to get a client like truly securely on a path sometimes, numerous attempts. But really, though, is a recognition of a highly risky behavior that is highly probable to cause death and such negative consequences in a person's life. And because of those impairments we discussed on decision making earlier, that's basically what they're portraying and what they're saying. Is that respecting that right, or not including that patient's right for preference? You know what I mean? I mean, there's intervention opportunities there, and there's opportunities to introduce the possibility of Suboxone, and there's a lot going on there. But as far as just to co-sign that is including, oh, how would that look if we put that on treatment plan? Client reports he wishes to just keep using 2 bundles of heroin a day, and we make objectives and whatnot, and interventions designed to help a client do that. And I'm being a little silly here, but also not, because it's on one extreme at the end, but it does point to what I'm trying to say today. The second question, what a client who is using 2 bundles of heroin a day and in professional opinion need. So again, person-centered care, preference, needs, and ability. The first video talked about those balances, no perfect recipe. That's what we're talking here. Would a client who is using 2 bundles of heroin a day, in your professional opinion, need inpatient and stabilization services? There might be other ways. I'm not going to negate it, but I'm just, for in a general sense, that would be the number one and best supported intervention. Next question. Would a client who may be resistant to agreeing to a recommendation of inpatient be automatically determined not to have the ability? Again, so you see a little resistance. Does that mean that person's just an addict and we just, that's what he is. It's never going to happen anyways. It's just an addict. Or do we see the person and recognize that maybe they just need a little encouragement, and maybe they just need some support. Maybe they need some persuasion and to strategies to increase buy-in. But so that resistance isn't just to throw your hands up. That resistance is a cue to switch gears and switch tactics and start educating and using clinical skills to help inform decision-making. Last one. Would a client's resistance, as mentioned above, be an automatic and didn't care into the right of fail, or should we work using our clinical skills, best practices, and training to educate clients, get through ambivalence, and increase buy-in to collaboratively decide to inpatient is the intervention that has the highest chance of success in achieving stability based on the client immediate needs, symptoms exhibited, and criteria met that 20 years of research with ASAM criteria indicates offers the best chances of success. I'm hoping that we all came to the same answers, and I'm assuming we did, so I'm going to move on. Person-centered planning should be a collaborative process resulting in recovery or in treatment planning. It should be directed by clients as much as possible, but it is produced in partnership, keyword partnership, with care providers and natural supporters. And a partnership is like anything. I mean, I have been married almost 20 years, and I think I have a great partnership with my wife, but there's times that through discussion and sometimes arguments, we have disagreements, and the partnership part comes in. Sometimes we go my wife's way, sometimes we go my wife's way. Or my way. That's funny. I said wife twice, but still, sometimes we go my wife's way, sometimes we go my way. And that is what a partnership is. In anything we do, in any relationship we have, it is a give and a take, and it is where both people contribute equally. And there's times that one might do more, and there's other times that the other person might do more. That is partnership in collaboration. Person-centered planning should support clients' preferences, but is always balanced with recovery orientation based in empirical research. Core principles in substance abuse training. Now, I got these guidelines. There's going to go through some slides, and they are from the National Institute of Drug Abuse site. Feel free to check them out. And then I also got some on here from SAMHSA's TAP 21 Core Competencies of Addiction Counselor. Excuse me. The first from the National Institutes of Drug Abuse. No single treatment is appropriate for everyone. Treatment varies depending on the type of drug and characteristics of the patients. Matching treatment settings, interventions, and service to an individual particular problems and needs is critical to his or her ultimate success in returning to productive function in the family, workplace, and society. Effective treatment attends to multiple needs of the individual, not just his or her drug abuse. So client's homeless, client's got housing, not conducive to recovery, client needs mental health services, primary care, all that kind of stuff. To be effective, treatment must address the individual's drug abuse and any associated medical, psychological, social, vocational, and legal problems. It is also important that the treatment be appropriate to the individual's age, gender, ethnicity, and culture. Treatment does not need to be voluntary to be effective. And again, you can lead a horse to water and you can't make him drink, and we can't, but sometimes the mandated way does work. And again, like, I think we need to shift our view with the legal systems, because it's when we work in partnership with them and in collaboration that it benefits the client. When we do things like not report or involve them, then they get a little suspicious and that rope gets a lot shorter. And that actually would be the opposite, because that is when they kind of pull that rope a little quicker. You know, if we got them in part of the whole process, we're being transparent and they're on board and the client's on board and we're all working together, it is much more effective. So I think that plays to this directly. Sanctions are enticements from family employment settings, and the criminal justice system can significantly increase treatment entry, retention rates, and the ultimate success of drug treatment intervention. All right, so these go into the core competencies from SAMHSA's tab 21. If you want a free copy, I put it in here. The core competencies that support this view are numerous in tab 21, with the person-centered care and the professional part, and when to make those determinations and differences. That person-centered plan is collaborative effort, but should also be based on what has been proven to work, but I've only selected a few. I could have kept going. I swear I almost did, but I figured I was getting a little too crazy with it. SAMHSA 21, competency 29, review the treatment options that are appropriate for the client's needs, characteristic goals, and financial resources. The skills in that competency include eliciting and determine relevant client characteristic needs and goals, making appropriate recommendations for treatment and use of other available community resources, again, as the professional, appropriate recommendations, collaborate with the client to determine the best course of action. And through collaboration, I mean, be clear, we're going to collaborate, but that goes back to what I said about a partnership. Both sides have a point, and if at the end of the day, we have to make treatment recommendations that we are ethically and professionally bound to make. The self-direction part's what comes in when they can choose to follow or not. I mean, we don't just throw our hands up, but when it gets there. Competency 30, apply accepted criteria for a diagnosis of substance use disorder and making treatment recommendations. The skills involved using current DSM and ASAM or other accepted diagnostic standards, using appropriate placement criteria. If the client meets criteria, the client meets criteria. You know what I mean? Obtaining information necessary to develop a diagnostic impression. Competency 34, analyze and interpret the data to determine treatment recommendation. Use scoring assessment tools, interpret data relevant to the client, use results to identify client needs and appropriate treatment options. So again, we're going there with needs and appropriate treatment options, which ultimately in early recovery and active use, that is the starting point. Communicate recommendations to the clients and appropriate service providers. Competency 34, use relevant assessment information to guide the treatment plan and process. The skills needed are establish treatment priorities based on all available assessment data. That's the client's report, that's urine analysis, that's reports from family, probation, parole, DSS, anything like that. You're taking all that in. Interpreting these assessment information concerning client's age, developmental level, treatment readiness, gender, and racial and ethnic culture. Use assessment information to individualize the client's treatment goals based on what they need and those social determinants and functional areas. Competency 42, prioritize the client's needs in order that they will be addressed in treatment. Skills needed are assessing referral sources necessary to address the client's need, using clinical judgment and prioritizing the client problems. And that's the part of the partnership that's where our clinical judgment comes into play. Assessing severity of client problems and prioritizing appropriately. It's got a little jumbled there. Provider responsibility starts with strength-based assessment. This includes a welcoming attitude, initial building trust and help in a relationship. Focusing on goals, preferences, and hopes can help engage people. Setting the stage, understanding the service individual's desire for change in the future, and participation in the planning process. So again, if we're looking for buy-in and participation in the planning process, we're talking about that resistance and all that other stuff we've been talking about. There might not even be a want to participate at that moment. Semi-structured assessment works well, have conversational approach while completing assessment in these domains. Strength-based assessment is about identifying strengths in multiple categories, identifying skills, personal characteristic, interests, past successes, hopes, and aspirations, identifying barriers and risk factors, and those barriers can include multiple things, include individual preference and expectations of services, and it involves recognition of the stages of change and what stage of recovery they're in. Because again, different stages of change, different stages of recovery, I have different interventions. Strength-based assessment puts in the person-centered treatment plan and involves using the data collected in assessment by itself is not sufficient for service planning. It moves from the what is happening to the why it's happening. You put your interventions to like get at that why, if that makes sense. It integrates and summarizes the data that have been collected, including understanding the meaning. It summarizes the perception of the person served and provides the practitioner's view, combines all of the above, and then recommends a course of treatment and determines the level of care. Clinical perspective and prioritizing of the treatment planning, and this is based on what we see and what we should be working on. And this, I'm talking like really straight from the door. the basic health and safety. I am a big advocate to understand how Maslow's hierarchy, I use it all the time working with clients. I do groups around and everything. I am a firm believer in a hierarchy. I mean, it is just a theory at the end of the day, and I do believe human beings don't fit in books, but especially those bottom levels, that physiological and safety needs. If we have a client in active use who is homeless and they are just stuck in there, we are not getting anywhere until we get those needs met, because they are so stuck in survival mode and defense mechanisms are up and a lot going on there until we get those things and they feel some security and some stability. And then we start working on those higher levels and where the therapeutic element comes. I mean, we're using clinical skills from the door, but like the therapy really cannot even start until we get that stuff out of the way. And that's what all this is kind of about, recognizing that and person-centered treatment plan planning to combat that and get that person to that level we need them to be at, whether it be an inpatient and maybe it's the outpatient people that's going to get them there, or maybe a client struggling in outpatient and they need to get sent to inpatient or residential to get, I mean, inpatients are always good because you usually get a bed pretty quick. So we get them inpatient while we're getting the housing piece set in place. By the time they get back to an outpatient, they're pretty secure. They got a length of sobriety in, head's pretty clear. They're making good decisions again, and those basic needs have been met. It's a reduction of clinical symptoms, and it's based on medical needs. They're practical needs. Harm reduction is a part of this. It's risk versus safety. You know, early on, like I said, I'll be the first to say, I mean, a harm reduction to me is a stage of treatment and a stage of recovery, but harm reduction is not a stopping point. And I think that's another misconception, and we will have a training down the road on that one as well. Harm reduction is an engagement phase, and it could take a while, and it's about going in and being willing to go in the gutter if it's needed with that client and stay with that client as long as it's needed, and being there anytime they need it to establish that rapport, to just increase therapeutic alliance. But the goal, the ultimate goal of anything is abstinence and what we do, and maybe not complete abstinence. I mean, I'm never going to say this to a client, because in early recovery stuff, we never know, you know, they're going to have to figure that out on their own. But I'll be the first to admit, if I have a client come to me shooting 2 bundles of heroin a day and along with a couple grams of cocaine and smoking weed once a week, if they leave me smoking weed, just smoking weed once a week, I mean, it's not complete abstinence, but I know that there's a severe improvement of quality of life, and I'm going to count that as a win. But just to even think of like those other drugs that come with such higher consequence on the same level, I mean, right there is a mistake. And again, even still, it's risky. I mean, I am a little bit old school here. I think all roads eventually leave, but I am realistic too sometimes. So again, there'll be another training on harm reduction. It is a starting point. It is not the end all be all. You know, that goes back to the right to fail, that we just throw our hands up at the first sign or things like that. You know, it's risk versus safety. Shooting 2 bundles of heroin comes with severe consequences. That's our starting point. It includes legal obligations, mandates, and it also is about community safe. So those are kind of in order the way I see them on what we need to prioritize when we are working in treatment planning. The goals and the dreams of the clients. And I'm being a little sarcastic there, but also not. I mean, sometimes I joke a lot, and I will tell people, and I mean this too, I swear to you I do. If a client that I'm working with and they are demonstrating self-direction that's going to lead directly back either through self-report, just owning it, like I'm not doing none of this, I want to keep using, or just by the actions, like I gave the example early on, wanting to go to emergency housing and be homeless, you know what I mean? In either one of those cases, I know those aren't good treatment planning and person-centered care. So I'm going to work kind of based more on what my clinical impression, what the client needs is. However, once a client's stable and they're going well and clear-eyed and making good decisions, and I'm watching that blossom, because if you've been in the field for a while, I'm seeing that this does happen, and I've seen it enough. It's a beautiful thing. I swear to you, if that client told me that they want to become president of the United States or work for NASA, if that is feasible, we are going to do that. And I will believe at my core it is possible, and I'm going to follow that all the way. And I think at that time, we're just giving resources, education where we can, but mostly we are working as cheerleaders, like, good job, keep it going. You know what I mean? And you've been doing it a while, you've seen it. You've seen people go back to school and rebuild their lives. You've seen people get married and buy homes and fix their credit and just total like turnaround. And that's the part where the first video, that balance, when to give a client time to grow and blossom, that is that time. But early on, person-centered care is based more on needs. Sometimes clinicians will need to peel the onion to determine the underlying reasons for the person's interests. So this takes using counseling skills such as discrepancy build in, recognize that individual has no intent to change behavior in the near future, and using interventions that match that and working through that imbalance. So that's kind of what we've been talking about the whole time, and kind of where I would like to try to refocus on our practice, all of us, because we can get better at this. It's definitely a skill, takes a little practice to get going, but it also takes a change in perspective. And I'm hoping that I was able to share that with you today. So that is all I got for now. I will see you soon. Have a good day.